So we support people in their own homes with medication, basically getting them independent, managing their medication safely. So the resource teams, they work fairly similarly, but also we kind of see slightly different patients in the Vale and in Cardiff. So our aim is to support patients that are coming out of hospital, that are identified in hospital, that need a bit of extra support, whether that's with meds or their normal kind of day-to-day lives, or patients that are at risk of going into hospital because they're acutely unwell, they're having frequent falls, or their conditions deteriorating. So we can put help in to stop them from going into hospital. So we work collaboratively with the rest of our team because we work in an MDT. So we have occupational therapists and physiotherapists and their assistants. We've got speech and language and dietetics. We've got falls technicians. We've got nurses from mental health and from the Safe at Home team, which again are helping people who are acutely unwell, maybe who need just like antibiotics, so they'll help them and keep them at home to stop them from going to hospital. We work with third sector, which is Age Connect, so they look at kind of all the social aspects, so cleaners, hairdressers, charities that do like befriending or volunteer transport, all that kind of thing. So we work with them as well. And on the social side, we've got our home care team. So they are the ones that commission the care, so they can put care in free of charge for 6 weeks. So when the patient comes home, either a home care manager or one of the OTs will go out and do that initial assessment to find out if they need care, how many care calls a day, and what other support they need from the health side of the team. So we get our referrals either from the hospital or the GP practices. We also get them in the Vale side from C1B, which is the social services single point of access, so anyone who's rung in with concerns about a family or friend that need help. And in Cardiff is the independent living services. We also get referrals from the memory team. And in Cardiff and Vale, most of the clusters have a discharge hub made up of pharmacists who review any medication changes on a discharge and implement those changes. So if they're ringing the patient or making any changes and they think there might be some issues with someone managing their medications, they can refer them into me if they're known to kind of the CRT team. So referrals are screened every morning. As I said, it's for 6 weeks. So ideally it's someone who's got rehab goals, so if they're just a bit deconditioned from doing their meds every day, they've been in hospital for a couple of months and need to get back up to baseline of mobility. They get free care for 6 weeks, but the therapists are generally involved a bit longer, especially with medications, because you've got to wait for medication cycles, new prescriptions. GPs don't always want to print another month's worth after they've maybe just done it within the last week, so we often have them involved a bit longer, or we get involved a bit later. We're not always kind of thought of maybe in the first few weeks, so it tends to be the end of the 6 weeks is when they start noticing the medication issues and then refer on to us. And then within that 6 weeks, they're then identified if they do actually need long-term support, either with meds, so it could be a meds-only care call, or if they need help with their other ADLs. Ideally, we don't put meds-only care calls in. We really struggle to get them in Cardiff, even though I know it's a bit easier for them in the Vale, so we'll try and get the patient independent so they don't need the care for that. In Cardiff, even though we do see similar patients, I see more dysphagia patients in Cardiff, so patients that struggle to swallow their medications. So I will go out and assess to find out which medications are causing an issue and finding an alternative that's best for the patient. Our home care team can only prompt medications if they're in a blister pack. So as soon as you're asking them to crush or dissolve or help with liquids, they can't do that. So it's kind of weighing up the risk of the patient having it every day, potentially coughing on it, or having a liquid where they'd be safer to take it, but then the carers can't prompt it, so you need either family or the patient to be able to remember to take it themselves. So it's a lot of logistical issues to sort that out. As an example, I had a gentleman he had a corkscrew esophagus, so he was struggling to swallow his pain relief, which one of the dietitians had highlighted. The wife was trying to snap the paracetamol because it's not coated, it was getting stuck in his throat and kind of dissolving in it. But because when it's snapped, it's got sharp edges, it was then getting stuck in his throat still. He's housebound and she can't leave him on his own, so she wasn't really sure what other alternatives are out there, so I said he could try capsules because he was on lansoprazole, which he was managing okay, or soluble tablet. So I discussed this with the third sector team with Age Connect, and they were going to look for someone to come and sit with him once a week. So their wife would have a bit of respite. She could go out to the shops and go and kind of look at these alternative medications because it wasn't prescribed, so they had to go and buy them themselves. When I looked through his medication, because I went through all of the items, even though he was only prescribed a couple of things, he lost a huge amount of weight since he'd come out of hospital, and he was having 3 monthly B12 injections. But due to his weight loss and his muscle loss, the only viable muscle the DNs could find was in his armpit. You can imagine how painful that is, having an injection there. So he was getting quite a lot of anxiety about having to have this and how painful it was. But because of his swallow, nobody'd really discussed any oral options with him. So we spoke about the B12 tablets. I took them out to him. He said they were small enough for him to manage, so he's now actually taking one of those every day, and now doesn't have to have the painful injections, and that's also freeing up the district nurse time for patients who need like insulin and dressings, who, you know, they're already stretched as it is. So we were able to switch that. So it was being centred around what he could manage. Just because he had this cortical esophagus didn't mean he couldn't manage anything, rather than just flat change him out to, or we'll give him injections for everything because of his swallow. And because I was going through all his meds with him, I was also able to find out he wasn't compliant with one of his supplements because they were the plain powder, and he was getting a lot of flavour fatigue. So I was able then to pass that back to the dietitians so that they could find the soups and the juice that were more suitable for him, that he was more likely to take, because he could have a variety of flavours. So that one worked really well, and we're hoping that helped with his put some of his weight back on.
So as Leanne said, we work in separate teams. Leanne's in Cardiff, we're in the Vale, but basically our role is the same. So our remit is to support people to independently manage their medication in their own homes, and we find that by going into people's homes, they're relaxed, they open up about what their issues are. There might be something simple, like somebody said earlier, I can't get into my bottle, so sometimes it's simple, at times more complex. So some of the patients we see are those with dementia, cognitive impairments, confusion usually, dexterity issues, sight impairment, Parkinson's disease. We see quite a lot of patients with Parkinson's, dysphagia for Leanne, and stroke patients. So, as I say, we've got a formal process now of assessing patients' medication management. So we've got a long list of questions, but we try to make it, nice and informal, get as much information out of the patients as we can about their concerns and, what's important to them and what their issues are, so their struggles really. Any solutions or suggestions we thoroughly discuss. We don't just go gung-ho and say, okay, Mr. Pat, we'll discuss everything. As I say, sometimes the intervention is tiny and it might just be a slight tweak to what they're already doing. We might need to just reorganise meds. That happens a lot, as you can imagine. So we go in with the current list of repeat medication discharged by centre or from GP practice. We reconcile all the meds in situ, and then we identify obsolete and dated expired meds a lot, return those to community pharmacy for safe disposal with consent from the patient, with written consent, and we record all of that. If there's any excess medication, we liaise with GP, usually the practice-based pharmacist and techs, and community pharmacy reordering. We try to minimise that being reordered and recycled properly. So counsel all medication. Obviously, we don't know why things are prescribed. A lot of them, we don't know detail, but we can just sort of say this is your blood pressure medication. Some patients know already, some don't, and they might question things. So we can feed all of that back then to GP practices. For example, they might say, I had one lady that said, well, I'm taking that medication 3 times a day for dizziness, but I'm still dizzy. So I had that back, and the GP stopped it. Reviewed, made sure that they were okay, but it was stopped. So we make sure patients are aware of special directions, so things like alendronic acid, and again we feed that back to GP practices if they can't manage that. Later we didn't we was literally laying down, so we thought, this is not very good, so we fed that back in place, and then the GP would decide whether to do it. We look at medication usage, so we talk about, we encourage patients to be honest with us about whether they're taking it or they're not. It might be that they're still having Senna every month and they're not constipated at all anymore, or it's just not suitable for them. So again, we can feed that back to GP practices. We try to optimise meds where we can to make things simple. Obviously that helps with adherence. We have numerous patients who are having twice daily Adherence and atorvastatin at night. That's the only thing that they take at night with the second dose of Durac, and they just don't take it. So we can get that changed once daily quite easily. We liaise with the secondary care pharmacy, pharmacist, and so we ask the pharmacist to look at the patients to see if they're suitable to switch to once daily Durac. So we've already done a lot of the work for the GP practice pharmacist. So we're not saying, can you look at this and you've got all this extra work. We've already done a lot of the work. So try to minimise overload and stop our good relationships that we've got, because we've built up some good relationships and we work well together. Sometimes patients are already having these and we notice that they're filled to the maximum when they don't need to be, so we get these optimised, and that facilitates, so for, as Leanne said, our carers, because of our medication policy, our carers are enabled to prompt medication unless it's dispensed from a pharmacy filled compliance aid. So if I got that changed from 4 times a day to twice daily, it frees up those 2 calls a day if the patient's having meds only calls, and someone else can then be looked at, supported by the service. And also if the patient then goes on to long-term medication package of care, it saves a lot of money. So we do that a lot as well. Synchronised med quantities, so I'm sure you're all aware that a lot of patients, the meds are all out of sync and they're having to phone pharmacies multiple times a month, GP practices, and so that saves time for all involved. We do inhaler technique training. We use the check device to check their inspiratory flow. I had a patient recently who his inhaler was changed in hospital, and he said, I just can't, I'm not getting that from it at all. And when I checked his flow, it was absolutely ridiculous. So then I fed that to GP. Eye drop. We have people with eye drops in some of these aids, this one and these are available on prescription, so I can get those put in place now.
We also do trialing of the compliance aids. So these are medication, these are reminder clocks. So we loan these to patients. Initially, when Deb came into post, she's been in post about 5 years. We had nothing, so she's emailed.
This is the 5-minute warning. Thank you.
She emailed companies to say, can we have something to look, and 5 years later we've still got the clocks. But we loan these out to patients. Patients like them. I know, how many times you've been on holiday and you wake up and think, oh, what day is it today? You look at your watch. These are great for patients as a reminder aid. They also have audio and visual aids. It's time to take your medication. It's time to watch Coronation Street. It's time to have a drink. But these are great. So these are probably our most successful compliance aid. We've also got the PAT dispenser there that the gentleman's fiddling with. This is an automatic pivotal pill dispenser, and these are about £130. But there's a Dosset box, but it's filled by the patient. Some services and UHBs have services. We don't do Cardiff and Vale. But this, if you flip the top over, there's a little window. So and then the alarm goes off. You can set it for once, twice, 3 times, 4 times a day. And it will then move around depending on how you set it. And you tip it up, then we usually say into a cereal bowl and collect all the medications. And then you can also allow it to stay open for 10 minutes, 15, 20, whatever you want to set it to. And then you can see if they've missed doses. It's really good for that. It's not very successful. Deb's used it a few times and hasn't been able to have much success. I've been in post 4 months and I've had one and it's really successful. So it really depends on the patient.